Hello and welcome. I'm Jeunesse Castonguay, VP at Clarius. Thank you for joining us for today's live webinar, Enhancing Precision in Oncoplastic Breast Surgery, the role of ultrasound in pre, peri, and postoperative assessment. We'll introduce you shortly to oncoplastic breast surgeon and passionate ultrasound advocate, Dr. Munir Ahmed, joining us from the UK to teach us POCUS best practices that improve oncologic effectiveness and aesthetic results for breast cancer patients. Please use the Q&A icon at any time during today's session to ask questions, which will be addressed after the presentation and live scanning session with sonographer and clinical manager Shelley Gunther. Let me now introduce you to your host for today's webinar. Dr. Frankel is trained in emergency medicine in California. A passionate POCUS educator, Dr. Frankel has been using point-of-care ultrasound his entire career. He practices in a busy academic teaching hospital in Vancouver as an emergency physician and serves as the chairman of our medical advisory board. Join me now in welcoming your host. Hi, Dr. Frankel.
Hi, Jeunesse. Thanks for having me here today. To set the stage for today's discussion, we did a broad literature review, and I wanted to highlight a few of the studies that came up to really frame our later discussion in terms of some of the evidence. The first paper I wanted to cover was a retrospective cross-sectional study of point-of-care ultrasound that focused particularly on palpable breast masses. And then the surgeons who used it, when they compared it to the gold standard histopathologic diagnosis, it demonstrated excellent accuracy with high sensitivity and specificity results, suggesting that performing breast ultrasound in the clinic pre-operatively can help the surgeon evaluate the extent of disease peri-operatively and can be then used to guide optimal surgical management for the patient. The next study I wanted to cover was more of a retrospective chart review across multiple centers within a single hospital healthcare center, but it also demonstrated that increasing familiarity with utilization of intraoperative ultrasound during breast conserving surgery can be clinically advantageous over traditional localization techniques such as wires or magnetic beads. And finally, I wanted to cover this more broad study, which was a prospective cohort study that investigated also use of intraoperative ultrasound that demonstrated that using it with surgery, thus using the intraoperative ultrasound to guide the surgical management, can obtain a high percentage of tumor-free margins in oncoplastic breast conserving surgery without introducing the unnecessary scheduling conflicts that can happen with other departments like radiology and nuclear, and then the surgery department who is participating in the surgery itself. And so before we jump into the meat of how to get deeper into this practice and how to incorporate it into your practice, we wanted to put this poll out there. We have practitioners from across the world at various states of practice. How frequently do you use ultrasound in your breast surgery practice? Is it something you're just learning about today, a rare thing, or something you actually use daily? We'll leave it out here for a second, and then we'll close it out, and we'll see where everybody is. So kind of across the board, about half of our participants just learning about it today, which is fabulous. So we have so much to share and learn, and we're so happy to bring in our special guest to help guide us in this, Dr. Munir Ahmed, who's a leading innovative and enthusiastic breast cancer surgeon who trained at the most advanced and comprehensive breast surgical oncology and reconstructive centers in the UK, Europe, and Japan. He was also awarded a PhD in surgical oncology. Along the way, he's been awarded multiple prestigious awards, including the Ronald Raven Traveling Fellowship by the British Association of Surgical Oncology, National Oncoplastic Breast Fellowship at the Charing Cross Hospital in London, Royal College of Surgeons of England Research Fellowship, and the European Society of Surgical Oncology Research Fellowship and RCS Ethicon Traveling Fellowship. In all, Dr. Ahmed strongly believes in advancing the field of breast surgery through his continued academic work and international collaborations for the benefits of his patients. And we can think of no better example than bringing him on board to share his expertise in this webinar. Dr. Ahmed, I'm going to hand it over to you.
Thank you very much for that introduction. So welcome, everyone. I'd like to start off and hope that everyone can gain something from something that I feel incredibly passionate about, and believe that if you apply this to your own clinical practice, it really will revolutionize the outcomes for your patients and also the satisfaction that you have with your own practice. So what we're going to discuss today is about my experiences with handheld portable ultrasound in an intraoperative surgical setting. So the first thing that we really need to look at, and I think is important, is what is the background to which I have developed my skills and my training within ultrasound. So really, it goes back to the period of time when I was doing my PhD research. And in my PhD research, the aim was to identify an optimal lesion localization technique. And ultimately, my project was really based upon developing the magnetic technique for lesion localization. So during that period of time, in trying to develop that aspect, I performed systematic reviews of all the different localization techniques which were currently available. So there were a variety of them. The majority of them were, of course, we have the standard of the wire-guided localization, but the other aspects which were more novel at the time, which included radioactive occult lesion localization, radioactive seed-guided localization, and as well as that, the aspect which I identified was intraoperative ultrasound. Now, when I started to compare the literature for all of these techniques, I started to see that there was a lot of potential in intraoperative ultrasound. As a result of that, it led me on to become more inquisitive and try and discover how I could develop ultrasound skills. Now, within the UK, there used to be a course called the Bristol Breast Ultrasound course for non-radiologists, which was an excellent course which involved several days of basic training, familiarity with applications of ultrasound, basic concepts of devices, interpretation from that perspective. It was then followed up by a logbook of over 100 cases, determining concordance in terms of clinical, radiological, and histopathological findings, and an assessment. And that's really where I started on the basis of that course. After that, in order to develop intraoperative ultrasound skills, I was awarded an SO fellowship by the British Association of Surgical Oncology in order to develop the skills in intraoperative ultrasound at the University of Vall d'Hebron in Barcelona under someone called Dr. Espinosa, an excellent sonographer and surgeon. And I was able to develop the skills which are acquired in those terms. I also went on further courses with ESO, and also within my higher surgical training within the UK, I performed a lot of intraoperative localizations in terms of wire-guided localization, which was performed under general anesthetic, so the patient's under anesthesia, and we used to localize the lesions from that perspective. And that was with an excellent mentor of myself, called Pato Faruhi, an excellent, again, surgeon and sonographer as well from that perspective. So that combined with the research, and also during that research, I had the opportunity to perform certain percutaneous ablative techniques, including high-intensity focused ultrasound. So it's really an extended body of work, which started from research through to practical applications and also novel applications themselves as well. So you can see it's an extensive period of time. It's not something that has been developed over a short period of time. And so we always have to look at the context of that. So going back to the period of research, during that time, this was one of the systematic reviews which I performed together with my PhD supervisor, Mr. Michael Dueck, or Professor Dueck now. So this looked at a systematic review of intraoperative ultrasound versus wire-guided localization in the management of non-palpable breast cancers. Now, the majority of the trials here are cohort studies with matched controls. There are no strong randomized control trials from that perspective. But if we look at the standardized comparison, what we're finding here is that intraoperative ultrasound is reducing the rate of re-excision of margins. If you compare this to any other technique, for example, traditionally at that time, if we looked at the novel techniques of radio-guided occult lesion localization or radioactive seed localization, none of those techniques had ever demonstrated superiority in reducing re-excision rates over the standard of a wire. So only intraoperative ultrasound has ever demonstrated that. Now, of course, now, there is the increasing trend to seed localization. And of course, during my PhD research period of time, we were the first unit over at Guy's Hospital that actually developed magnetic localization. But even with the newer techniques of seed localization, again, there's never been any evidence of reduced re-excision rates by application of seeds. The benefit of seeds can be potential and logistical benefit, but again, no demonstration of reduced re-excision rates. So intraoperative ultrasound, which has been available for a long period of time, is the only technique which has ever been able to demonstrate this reduced re-excision rate. So a good trial which looked at this, and I think this is very useful for anyone who is considering starting to perform intraoperative ultrasound. Excellent Dutch trial. Netherlands really does lead the way with some very well organized trials. And this is a randomized controlled trial, a multi-center trial, which compared palpation only performed surgery, so palpable tumors, so palpation alone versus intraoperative ultrasound-guided excision. And so they randomized two groups. And if you look at this, with regards to the outcomes of these randomized groups, you're finding that the intraoperative ultrasound is not only statistically significantly reducing the rate of re-excision margins, but it is also reducing the volume of tissue which is excised, which again is beneficial for several different functions, potentially with regard to the aesthetic outcome, but it also allows more standardized or basic incision potentially to be applied rather than extensive glandular mobilization and extensive oncoplastic techniques, which can have additional complications in terms of fat necrosis. So if anyone who's considering of starting intraoperative ultrasound, starting with palpable lesions is a very excellent way to begin your journey. So this then leads on to the question, so why should breast surgeons use ultrasound? And this is an editorial that we wrote several years ago regarding that. And again, there's several reasons clearly, and we'll allude into those from that perspective. There's several different reasons. Why can you, I mean, when you look at this, you need to compartmentalize it into different components. So there are a variety of different aspects within the clinic towards intraoperative ultrasound, and then also within the post-operative setting. And I will allude to those going forward. Now, if there are benefits of using ultrasound, why do breast surgeons not all use it? What is the limitation? So there've been a variety of surveys which have been conducted across the world. I mean, if you look at this, an ANZ survey, almost half of the surgeons were saying that there's a limitation in terms of access to ultrasound. A third of surgeons are saying that they just don't have the confidence in performing scans from that perspective. And this is another aspect that is worth discussing, and that is always the conflict that there is potentially with radiology. And that is an area to be approached from that perspective. I mean, I think to avoid any issue, and what I would always advocate is that the role of the radiologist is to characterize lesions, and that is quite clearly defined. Characterization using a very high definition departmental ultrasound scanner is something that should always be advocated. It is quite distinct to the clinical application that the surgeon will use, because the role of the surgeon is quite clearly different to that of the radiologist. Now, other aspects of limitation from the breast surgical perspective is potentially time pressures in the clinic. Some people will inevitably, on starting, have a lack of confidence or even concerns with regard to medical legal issues. And as I described earlier on, how we approach this is to ensure the radiologist performs characterization of lesions. And then if you're starting the process for intraoperative surgery, to look at palpable lesions from a starting point. So what kind of applications or indications can we have for ultrasound for the breast surgeon? So as I mentioned earlier on, you have that compartmentalization, separation of palpable versus non-palpable lesions. And I think that's useful because if you're starting, as I've mentioned, start with the palpable lesions, a lot safer from that perspective. Surgical planning. Okay, so what can it be used for? Now, in essence, I think if you know exactly where the lesion is by scanning within the clinic, it can always get you able to identify in your mind quite clearly where your incision placement potentially is going to be. Now, if you're going to be performing therapeutic mammoplasties, it can be very useful, again, to know the exact location of the lesion in order to determine the type of pedicle or approach that you will have for your oncoplastic procedures. So certainly surgical planning, I think, is imperative. And if you're going to be doing the application, perform the application of intraoperative ultrasound, it's very important to do that planning, because everything, your surgery, is determined by how you plan beforehand. Okay, you have to be familiar with the location of the lesions, and that gives you your best preparation. Now, of course, intraoperatively, it allows you to perform your localized excision without wires, without seeds, gives you that logistical flexibility from that perspective. It allows you to have real-time intraoperative visualization of the lesion, which is the only technique which allows you to do that. And also you can have the ex vivo margin assessment as well from that perspective. Now, what can be useful as well in terms of breast reconstruction can be determining skin flap assessment. Now, obviously, implant-based reconstruction, which a large majority of breast surgeons will perform, can be performed either prepectorally or subpectorally. And by performing ultrasound in the clinic, one can determine the thickness of flaps and suitability of prepectoral reconstruction compared to subpectoral implantation from that perspective. It can also be used for the application and suitability of IORT from that perspective as well in units which conduct that. What's very useful is post-operative assessment. Now, post-operative assessment in terms of seroma, abscess aspiration, it's always very useful because you always have your scanner available. You do not require a radiologist, and you can deal with your post-operative complications. Of course, if someone comes in through the emergency room with an issue such as abscess, again, out of hours, limited radiological capacity, if you've got the scanner with you, then you're able to deal with this yourself from that perspective. Auxiliary surgery. Increasingly now, pre-operatively, when I review my patients and mark them up for surgery, I've started to scan the axilla. So by scanning the axilla, noting the position of the lymph nodes in the axilla, and just literally marking that area, almost invariably it is concordant with the peak hotspot from the gamma probe during sentinel node biopsy. And so it can be very useful to help target your surgery in that regard. Of course, there's increasing use of de-escalation of auxiliary management, particularly in the neoadjuvant chemotherapy setting. And so in terms of targeted auxiliary dissection, application of ultrasound is very useful. If a patient has had an ultrasound visible marker clip inserted, particularly like T3 hydromark clips, then this can be followed through the patient's journey, and then ultrasound can be used intraoperatively in order to excise the targeted clip node. So it's a very useful application from that perspective. I think one other aspect which probably I've missed out on here is that increasingly the use of seeds can lead to issues in terms of migration of seeds jumping out during localization. So even if you're not using intraoperative ultrasound purely for lesion excision in its entirety, I think it's always useful to have the ultrasound and those skills available as a backup in case the seeds do jump out. If it's lost, you're able to maintain your control for the safety of the patient and prevent complications going forward. What's interesting in terms of training is that if we look at the Cobalt study and some of the other work by Prekel et al., who really, from what I've reviewed previously in the literature, really laid the foundation for a lot of this work, is that the level of training which is actually required in order to develop the skills for intraoperative ultrasound is relatively small. What they were able to identify was that surgeons who'd had previous experience of using ultrasound within the clinic only required around about 5 cases to become quite proficient in terms of performing intraoperative ultrasound, once initially supervised by a specialist in ultrasonography, be that either surgeon or radiologist. Those who had less experience only required up to 10 cases. So realistically, it's not a very steep learning curve from that perspective, and the evidence really does support that. So I really would encourage anyone who considers using the ultrasound intraoperatively to try that with palpable lesions. So here's an interesting study looking at ultrasound use by breast surgeons in the outpatient clinic. And if you look at some of these results, it's probably quite reassuring. I've discussed this once at a meeting with radiologists present. Wow, I got attacked by these radiologists. So I don't know how many radiologists there are over watching this. But if you look, what you find is between a radiologist and a surgeon performing ultrasound, the discordance is actually relatively small. It's less than 4%. And if you look at this, the surgeons get it right more often than the radiologists. So there's probably a lot more thinking or over-assessment by radiologists to a certain extent. And the surgeon is actually applying more of a clinical context to how the patient is presenting and the likelihood of their diagnosis. So really, I think anyone who wants to take up ultrasound, be reassured from that perspective. The evidence is on your side. And really, what are you trying to look at? There's certain characteristics that you want to look at between lesions. You obviously want to look at, is something malignant or is it benign? But in essence, the premise is really to define between a solid lesion and a lesion which consists of fluid. And I think looking at basic images and then the more malignant types and becoming familiar with that is the important aspect. And you start that by having the radiologist characterizing the lesions, knowing where the lesions are, and start doing a focused ultrasound in that area, identify the lesions, and go forward from there. So one very useful application, which I didn't mention earlier on, is looking at your response of patients to neoadjuvant chemotherapy. Now, I've found that this is a very rewarding and very useful technique, and the patients really do enjoy it. I'll find it very reassuring. So patients with tumors, to check how they are responding, obviously they can have their standard imaging in the radiology department, but when you see them in the clinic, it's always very useful to perform the scan and then also reassure them that the lesion is reducing. And the patients always ask me, what's going on? You can tell them, you can reassure them. Here's one example. If you look, this is quite a complex case I'm yet to operate on. There's a patient who has 3 lesions. And so if you look, you can see there are 2 solid lesions. And then there's one area, let's mark it up. Yeah, so we've got solid lesion here, one of the smaller lesions. This was the index presenting lesion. And this was one identified on MRI. And then subsequently, there's an area of DCIS. So you've got 2 solid lesions here. And then here you've got the biopsy site with a hematoma, which is confirmed DCIS. So you have this from that perspective, and you can see there's the distance from one of the further clips there. So this is pre-neoadjuvant chemotherapy. And then if we go towards the end of their neoadjuvant chemotherapy and we start considering surgical planning. So one solid lesion that we had here, and you can see all we have left is now this marker clip in situ. if we then look at the other solid lesion, and this was the bulk of the lesion. So here's an area of fibrosis, but here's the clip itself. So we can see 2 clips, the distance from the nipple. And then here, I'd say with this clip, it's harder to see. And so I've had to have a replacement clip placed, but there's still part of the hematoma, which is still not incompletely resolved from that perspective. So we can see the improvement, the response to neoadjuvant chemotherapy. And in the clinic, it's very reassuring for the patient to be told immediately that their cancers are responding. And so I think this is an increasingly useful application of ultrasound. So with regard to intraoperative ultrasound-guided surgery, I mentioned earlier, what are we trying to achieve? Well, you want to try and optimize your incision location. It really does help you in your planning. And if there are any people online who've seen me doing this, they will know that I do spend quite an extensive time in order to try and be to confirm the location of the lesion, and then work through my mind what are the different options in terms of lesion incisions. And it's quite useful in order to discuss this with the patient, because in real time you're able to identify in the clinic the position of that lesion, and then you can have an open discussion with regard to practicalities of your incision. And patients do like that. It gives them the context into your thinking behind the incision placement. We've talked about intraoperative margin assessment from the ex vivo perspective, but also real-time dynamic intraoperative assessment. And that will really be demonstrated in the videos that I'm going to show going forward. So here is a running video of one of the first generation systems. So this isn't the current system, but this is the basic principle of how intraoperative ultrasound-guided surgery is performed. So I've done my skin incision, I've determined my placement, and this was for a palpable lesion. You can see the image on the system there. And so in essence, once I've determined my incision placement, what I'm doing next is now making sure I'm adequately orientated around the lesion, and then I want to determine my margin. So you pick your margin. Generally, I always tend to go for the superior margin first, make sure I've got adequate clearance on the imaging, and then proceed to incising that area. So you just get your assistant to retract, make sure the area is completely fixed down, and then start your incision down to the pectoral fascia. So once you've done that, you're able to mobilize the lesion somewhat, and then you move forward, and then you choose your next margin. So here, we've done one part. Now I'm going to look for my next margin from that perspective. So again, you see there's our solid lesion. Now I'm looking for a margin. I'm looking for 1 centimeter clearance. You would remember the horizontal on the base is 4 centimeters. So if I am looking at a margin there, I'm going to aim for around about 1 centimeter. When I've got that 1 centimeter clearance, I then go down with the incision and go down on that margin from that perspective. So here we go. We're going for that. You see, I'm going closer and closer to that aspect. Probably a little bit generous there. There's quite a large lesion. So I've marked my position there, and then I'm making my incision going down from that perspective there. And
Dr. Ahmed,
so,
you're marking with your finger and mentally where your margin is to
yeah,
incise.
exactly.
Mm-hmm.
So I've marked down with my finger. I've got the ultrasound, and then I've marked down with my finger, and then I'm going to make my incision at that point there. The assistant can assist in terms of the retraction. And then you go and you proceed with this in all margins, and then you can also perform it ex vivo. So you can see the lesions now coming out from that perspective, and then we can move forward and do the ex vivo assessment from that perspective. So I think it's almost out. There we go. All right, brilliant. So after that, you've got the lesion out, and so now you can run through ex vivo assessment. So use the ultrasound, orientate the different margins, and make sure you've got adequate clearance. If you need to take any more tissue, then you can do that and take further shaves. I have to say, Compared to my colleagues, I really don't have the need to do additional shaves because I've done all of my excision under real-time intraoperative monitoring. So it's very rare unless there's extensive MC microcalcification present from that perspective. So let's look at a case. So it's quite an interesting case. A 50-year-old female was diagnosed with bilateral breast cancer. The left side was the symptomatic side, a triple positive cancer, significant in size, 39 millimeters, triple positive with a contralateral incidental smaller tumor, which was HER2 negative. She underwent neoadjuvant chemotherapy, had a complete radiological response. The patient herself would have been suitable for rather level 1 oncoplastic surgery, but she really opted for a more oncocosmetic approach and requested bilateral therapeutic mammoplasties and sentinel node biopsy. So let's go through some of the videos regarding that. So where do we start? Post-neoadjuvant chemotherapy, I'm going to see the patient in the clinic, and we're going to start assessing the surgical planning in terms of the clips. So what we do in the clinic here, I'm assessing the response post-neoadjuvant chemotherapy. And so what I'm doing, I've looked at previous imaging. We know she's had a complete radiological response. So I know the positions of the clips because I previously assessed her repeatedly during her journey. And so now I'm looking at the clips from that perspective. So now the clip is in the center. I don't know if you can see that well. It's a T3 hydromark clip, which is present. And so I'm looking at that. I've identified it. I'm identifying it in two different planes. So the radial and the anti-radial plane from that perspective. And once I've identified it, I then have performed a mark on the area there as well. Usually in the clinic, I have to say, I don't tend to mark routinely like this. But in this situation, what I was looking at was to determine the suitable pedicle placement for the patient in view of the bilateral therapeutic mammoplasties. So now we're going on to the contralateral side, again, performing the scan, trying to find those clips there. And the important thing with ultrasound, there you go, you can see it in the center. Can you see that little area there? There, excellent. You can see that little white clip there. So the white clip surrounded by the hypoechoic area, the T3 hydromark clip. It's a very well visualized clip the majority of the time, and then I am marking the position there. So obviously I'm looking at it, it's more laterally located, so you can think about your pedicle placement using medial or supramedial pedicle can be very applicable in this situation. But the principle is identify the location of the clips, identify them in the radial and anti-radial planes, and then you can perform your surgical planning accordingly. And what I have to say is, you cannot do enough planning in the clinic. That's where all the work in essence is done. The operating is really the straightforward bit. You need to know the area that you are targeting from that perspective. So now we go on to the big event. So the intraoperative ultrasound-guided surgery from that perspective. So I've marked the clips pre-operatively. I then performed my therapeutic mammoplasty markings as well. And now I move to the application of the surgical excision from that perspective. Now, here we're using the new kit from that perspective. So a lot smaller, a lot sleeker, a lot more practical. But here's the principle again. Like say, you've marked the area, you know where the clips are. Now you want to find them in real time again from that perspective. So here we go. You can't do this enough times. So I'm scanning here. We've already marked therapeutic mammoplasty. So here we see the clip, which is there from that perspective. Again, go in the radial, anti-radial planes from that perspective, identify it. Okay, so I'm satisfied that I've identified where the clip is. And so now I'm going to start my incision from that perspective. So again, you want to determine your incision pre-operatively, have in your mind your plan, and only modify it if necessary. So again, relatively complex incisions here with the therapeutic mammoplasty, but the same principles apply. So make the incision, that continue to optimize and monitor the clip. What you have to realize is that the image does change from the scan, which is performed on the skin, compared to when you're performing it intraoperatively, and that is something to be aware of. So frequently perform the scan in order to confirm you're happy with the position of the clip, of the lesion, and go from there, from that perspective. Now, with regard to positioning your incisions, again, that is something to be aware of. Now, in view of saying that the image does change between the scan on the skin and intraoperatively, it means that really you have to become familiar with different changes which occur. And also it's best to try and avoid very extreme remote incisions, because with the variation of angle of the image that can change, and if you're targeting very small clips, such as in this case, it can be more sensible to try and go for more direct access from that perspective, or at least make sure you've chosen a suitable oncoplastic incision. So if we look here, as with the previous video, I'm using the ultrasound to identify the clip, and then I'm trying to identify the margin distance. So on the base of the scanner here, what you see is this will be 4 centimeters. Now, I want to get a reasonable margin from this area. So I'm looking at my margin. So my margin is going to be on this side. So what I want to do is I want to have it at around about 1 centimeter. And when I've got it at around about 1 centimeter from the edge of the probe, then I'm fixing down the area and I'm making the incision downward. So fix that area, make the incision, and then go downward in order to assess that margin from that perspective, and then go forward. Okay, so you apply the same principle over and over again. Now, I'd say in this case, now I had to make the decision of the type of incision to make. It was a very, very small clip. It was actually becoming a little bit ill-defined intraoperatively. So we decided, rather than mobilizing excessive glandular tissue, to go for a more direct approach. And so here again, it's just the same principle. So I know it's repetitive, but it's the same principle here. Identify the clip. So you look at the clip in one plane. I'll then perform it in the anti-radial plane. There's the other plane. So we're going at right angles to each other. See if I can see it. Right. Once I've identified that, determine the incision and go accordingly from that perspective. You're going to then circumferentially determine all of the margins, remove the lesion, and then perform ex vivo assessment, and go from there. Okay, let's go on. So once you've done your surgery, all right, that isn't, as we know, that isn't the end of everything. Quite often it could be the start of issues and problems. So what's an application post-operatively? Now, I was talking about post-operative seromas, hematomas, and the opportunity to just effectively drain these with minimal discomfort, quite rapidly when necessary, and without radiological input, because it's very difficult to sometimes get a radiologist who's available for this. So here's, one quite straightforward application in the clinic, post-operative seroma. You just orientate yourself. And again, this is one of the skills that you need to advance, particularly is being familiar with lining up the needle perpendicularly to the probe and to perform aspiration. So this one went quite well. The needle straight in, you can see it nice in parallax to the probe. You can see the fluid just disappear on aspiration. And again, rather than just blindly performing this, pushing the needle in and out and hoping you get something out, it's all done in a very, very controlled fashion, very satisfying. Again, you can apply this in the infective setting if someone's got an abscess as well from that perspective. So again, works very well from that perspective. So in conclusion, what I would say is that anyone who starts using ultrasound really will find that it revolutionizes their practice. It really allows the surgeon, particularly with regard to localization guided surgery to have complete control. Even if you're not using intraoperative ultrasound as your main modality in terms of excision, I think it adds an extra safety dimension, particularly to the application of seed localization, where seeds can quite easily migrate, and the same with regard to wires. So even in that most conservative setting, I think applying and learning basic ultrasound skills is extremely useful and safe for the patient from that perspective. In the past, I have to say the extent to which I was able to use ultrasound was limited by availability of ultrasound and lack of portability of ultrasound. Now, with portability, it's no longer really an issue. This is handheld devices which can be carried around with you everywhere you go. So you always have that access. So you don't really have any excuse to say you can't apply ultrasound in a more extensive setting from that perspective. It obviously has those intraoperative and outpatient applications in the post-operative setting. And I just reinforce, for any radiologists who may be feeling insecure out there, I have no intention of removing you from employment from any perspective. You are there to characterize those lesions. That is your job. My job is to remove those lesions with clear margins in as safe a manner as possible. And that is what the breast surgeon should do. The ultrasound just enhances that for yourself, for the patient's safety, and for evidence-based outcomes from that perspective. As you can see, the process is relatively well standardized. And I think from a lot of the clips that I've shown, you can see it is quite repetitive. And repetition is good. Being boring in surgery is even better, because, if, as one of my mentors told me, if you're doing something exciting in surgery, then you're probably doing something wrong. You should try and keep it as boring as flying a plane. You don't want any issue with that. It should just be dull. And so just get familiar with the techniques, and I think you can make things very straightforward, and I'm more than happy to take any questions going forward. Thank you.
Great. Thanks so much, Dr. Ahmed, for that excellent educational content. I see there's a lot of questions filing into the Q&A, so please keep using that, and we will get to those before the top of the hour. But first, we're going to hand it over to Shelley Gunther, our clinical marketing manager, for a quick demo.
Thank you, and a great talk. I'm going to just use our L15 scanner and head over to our model, and I'll just show you a little bit of what we can do with the Clarius. Good. So like I said, I'm using the L15 scanner, and we're using the diagnostic breast preset, which is shown right up here. So you also have the option of doing a interventional breast preset down here, and that's if you're doing biopsies. It's just going to give you some biopsy labeling just to keep things organized, but we will use the diagnostic breast preset, and then we'll just start scanning here. And one thing that we can get with the diagnostic preset is when I go into the tools, we also get the luxury of getting a few extra volume measurements for lesions and depth to width ratios. With breast masses, if we have a ratio of greater than one, that's usually not a good sign with the lesion. It needs to be investigated. And the other last tool that I want to show you, and this is new, is something called voice controls. And so, Dr. Ahmed, you were working and not able to make adjustments on the screen when you're in the OR, obviously, but now I can tell our system increase depth and decrease depth, increase gain. And you can see that the command does show up here as well. And when I'm just looking at the breast tissue here, we're seeing skin at the surface, some fatty tissue here, and down below, we can see shadows from the ribs as well as some lung sliding here. So we have pec muscle here. So everything between here and here is breast tissue. And then this is normal glandular tissue here. It's a little bit ridgy, which is perfectly normal. increase depth, freeze, capture image. Another tool that I'll show you is something called pictograms, which is really nice for breast imaging. If you don't want to be doing labels, you can just select the pictogram that you like. You can also put a toggle indicator just to show the viewer where your scanner is. And then once you have what you want, that will show up on your screen and you can move that around to wherever you like it. So this is really nice for indicating the position of your scanner, just for follow-up imaging, increase depth, decrease depth, decrease depth. Freeze, capture image. Freeze. If we're doing a procedure, I can also capture a video. And that's going to just grab a nice cine loop for us. Freeze. Great.
Thanks, Shelley. I can see how a lot of that could be applicable both intraoperative and in the outpatient setting too.
Yeah, definitely. And it's a really, really easy to use tool for us. So,
all right, well, keep using the Q&A, please, to all our participants. We are going to get to the questions in just a moment. First, I'm going to hand it back over to Janez.
Thanks, Aran, and thank you, Shelley, for the fabulous live demonstration. And thank you, Dr. Ahmed, for sharing your ultrasound best practices for breast surgery applications with us here today. Before we open up the floor to live questions, and please do use the Q&A icon to ask your questions, we'd like to first ask you a question in a quick poll. We'd love to help everyone continue their journey in bringing handheld ultrasound guidance to their practice. Please complete this poll to let us know if we can provide further information. Price and availability does vary by region, so feel free to request a quote and pricing, and you can click on as many options as you like here. You may opt to speak to one of our experts about the advantages of wireless ultrasound. If you'd like to discuss scanner features, please select that option, and you can book a virtual one-on-one demo with our experts to see the new Claris HD3 in action in a highly interactive one-on-one session. And we can also send you more video tutorials for point-of-care ultrasound. So please go ahead and select as many options as you wish. While you complete the live poll, I'll take a minute to introduce you to Claris HD3. It's the world's only third-generation line of handheld ultrasound scanners. They're 30% smaller, lighter, and more affordable. And Claris HD3 delivers best-in-class wireless ultrasound system for breast imaging with an easy-to-use app powered by artificial intelligence and connected to the cloud, plus an advanced breast package with specialized tools for breast examinations and procedures. The Claris L15 HD3 linear scanner is specifically designed for effectively imaging breast tissue in high definition to confidently identify and characterize abnormalities with needle enhance, and you can safely and accurately guide your procedures with superior tissue and needle imaging. Claris delivers several advantages. With 8 times the processing power of most handheld ultrasound systems, Claris is unrivaled for near-field and high-resolution imaging. The secret lies in the design, with each scanner featuring not 1, not 2, but 8 beamformers, 192 elements, and AI that together deliver the image quality only found in compact systems, but at a fraction of the cost, representing 85% in savings. And this user experience is phenomenal. With AI and voice controls replacing complex knobs and buttons, it's as easy to use as your smartphone. Claris is also wireless, freeing up space with zero footprint for ultra portability in a variety of settings, from the clinic to the operating room. You get free movement with no wires getting in the way and touching your sterile prep area. With no wires, Claris is also so much faster to clean, disinfect, or fully encase in a sterile bag. And you can place your tablet or phone anywhere, so your display is directly in your line of sight. Only Claris delivers linear scanners with an ecosystem that includes a free app for your iOS and Android devices for unlimited users. Available with our membership, Claris Cloud is used to easily capture and manage unlimited exams from anywhere. Your membership also includes in-app Claris classroom videos with experts like Dr. Ahmed, and onboarding with the Claris clinician to build your skills. Claris Live delivers one-click telemedicine if you'd like to share live scanning with a colleague for a second opinion. And you get advanced features like voice controls, elastography, and split screen. With your membership, you also get the advanced breast package that includes dedicated presets for diagnostic exams like you saw today and interventional breast procedures, triplane pictograms, a rapid annotation picker, BI-RADS reporting, lesion indications, biopsy needle enhance, and the biopsy labeling protocol. Thank you for participating in the poll. If you ask for more information, we will get back to you in the coming week. I'd like to welcome back Dr. Ahmed and Dr. Frankel to answer your questions. Please use the Q&A icon in the menu bar to ask your questions of our great clinicians. Dr. Frankel, if I could ask you to moderate, please.
Yeah, happy to. We have a lot of questions, so let's just jump right in. First question, which is very common in our webinars, Dr. Ahmed, is how do people learn more? How do they get hands-on training and learn how to identify images that they do see on their scanner?
So what I'd say is the first way forward is to make sure that you have easy access to an ultrasound. So here's the first way that you can achieve that. All right, clearly, you know the place to go. Once you've got access to the ultrasound in the clinic, you'll have a patient who's there. The lesion's characterized by the radiologist. You look at the conventional imaging. You look at the ultrasound scan performed by the radiologist. You look at the location of the lesion, and then examine the patient. Do your examination. If it's a screening patient, a non-palpable lesion, then it's more challenging to start with, but start doing the scan. See what you see. Get familiar with what your radiologist is seeing from that perspective. And then over time, you will become more familiar with the images. And really what you want to look at is be confident in discriminating between benign and malignant lesions. That's what you want to be confident about. But you have to remember, you're not really there to characterize the lesions. If you're trying to excise it, you just want to be able to localize them. So, but still you can have multiple different lesions. So it's important, but just try and learn from the scan, which is performed by the radiologist, pick up from there, become confident in identifying the lesion. That's number one. If you then want to perform the operation itself, now, if there's a palpable lesion, you will just go and do that operation, in essence, blind with your fingertips. So where's the harm in applying the ultrasound in order to start your orientation in determining the margins, so the superior, the inferior margin, medial, lateral? Become familiar with it from that perspective. As your confidence grows, as you see your re-excision rate decreasing and you become more confident, then move on to the non-palpable lesions. You can start with the non-palpable lesions, have a seed present, have a wire present, start using the ultrasound for that orientation from that perspective. And so you start steadily increase your confidence, and then you can continue to move forward from that perspective. I would just recommend that just do the scans on everything that you can in the clinic. Make sure that you're concordant with your radiologist. Tell your radiologist in a one-stop clinic, I want to do some scans as well, and have a discussion with them so you could scan, and then the radiologist can scan, compare your findings to the radiologist's findings. Develop your confidence from that perspective, okay? There are a variety of different courses which are available to a certain extent around the world. I think that's always useful. The most important aspect is that logbook of becoming yourself scanning on a regular basis. So if you're doing this on a daily basis with a portable ultrasound, you're going to become very familiar with what's going on quite rapidly from that perspective. Anyone who wants to learn intraoperative ultrasound, and if they're ever in London, I'm more than happy to take people through some cases during my operating, no problem. So I think, I'm very happy to offer that. And I think, go from there. It is something you will never regret from that perspective.
Great, thank you so much. I love the collaborative approach with the radiologists to compare scans, and it also kind of helps build that relationship instead of add any kind of clash like you had identified earlier that might be misinterpreted. I'd also mention maybe in the outpatient setting, you demonstrated a lot of outpatient use, particularly seroma drainage, things you would be doing blind anyway, where the ultrasound really just helps you become more accurate. and more effective and improve your patient satisfaction as good ways to introduce its use as well. Another question, quick and easy. Do you use gel when you're doing intraoperative ultrasound?
Yeah, so yeah, I mean, I didn't show how the probe was prepped, but in essence, when you're prepping the probe, you place, and this would apply for any ultrasound, intraoperatively, you put gel on the probe, so directly onto the probe. And then when you put the plastic cover, the sleeve on top of that, you have that gel directly inside the sleeve on top of, on the probe. So that's there. And then intraoperatively, when you're doing the scanning, you use gel externally on the skin. So there has to be the interface of gel directly onto the probe head inside the sleeve, but also then on the skin surface. Intraoperatively, when you're inside the wound, it does help to have some additional gel. Sometimes you don't always need it, but generally I would use that to enhance the imaging. So in summary, you use the gel inside the sleeve and then also inside the wound as well.
Great. And how do you showed kind of marking the margins with your finger? Are there other ways to do it because you remove the probe intraoperatively so that you can kind of mark it somehow, like when you put the wire in, you sort of leave the wire in place during the surgery? Are there other techniques you can use besides just the finger?
Yeah, I mean, I think it's the standard. So when we do a standard excision, so if you were using for example, a wire, or if you were using just palpation alone, you have to determine the point at which you're fixing down the tumor in order to make your position of incision. So with this, I'm using you have probably the other option is use the probe, identify your margin so you have that position. So and the way that I was taught to do that was then at that position of where the probe is fixed and I want to make my incision, place my finger there and then start the incision and have the assistant to retract with the Langenbeck's retractors. Another option is potentially you could use a marker and just put a little mark there, but then you're just going to have to place your finger there to fix down the area so that the area is under tension and make the incision. So the most straightforward way is just to use your finger from that perspective in order to identify the position to excise down perpendicularly.
Great. Well, thanks so much for that. We're at the top of the hour. I know there's a few more questions we weren't able to get to, but we will be following up with those soon. We appreciate everybody's time, and I'll hand it back to Janez to close us out here.
Thank you so much. And thank you for all your questions. We will get back to you in the coming week if we didn't get to yours. You will also all receive a PDF copy of the slides. And we did record today's session, so you will receive a copy of the recording by email in the coming days as well. I'd like to thank Dr. Ahmed for sharing all of his point-of-care ultrasound best practices with us. And a big thank you to all of you for joining us here today. I hope you have a wonderful rest of your day and keep scanning. Thank you.
Bye, everyone.
Thanks everyone. Bye.
Bye now.